to the 2018 STL Talk Seminar. I believe this is our fourth or fifth one, and we're super excited to have everyone here with us this morning. On behalf of the admins, my name is Brad Key, Kelly Williams, Jenny Key, and Jen Nemo. We're the admins, and we run the group here. And we really thank you for coming out today. We've got plenty of food, we've got plenty of salty snacks and drinks around. There's normal light samples and different things out there, so feel free to take those. If you haven't checked in when you came in, we do have a few prize giveaways that we're doing, so if you haven't checked your name off, please go ahead and do that. So you're into the prize giveaways. I think that's it for announcements, isn't it? We will take plenty of breaks, so don't worry about that. It's a laid-back atmosphere, so feel free to get up, walk around. We'll have basically one speaker, and then we'll take a break and have another speaker. So plenty of time to get up and use the restroom and stretch your with us. So thank you for joining us. And first off, I'd like to introduce Dr. Antonella Quattromani.
Thank you. Thank you for inviting me. I am currently working at Fort Leonard in the cardiology department, which we saved from the evil of the government who was going to try to shut us down, but we stayed on. I've been involved with the POTS and autonomic dysfunction for quite some time. In fact, to give you a little history, my trainer, my mentor, Washu, started this in the 80s, and when nobody even believed until table test, and we had like really a space the size of a closet where we start mostly testing children and young adults, and then moved on to SLU. We did some work with the neurology department there where we studied the brain perfusion during syncope in patients with POTS. And then, I personally had the experience of having a daughter with POTS. She developed POTS when she was 21 in Boston doing college engineering, and it was very debilitating for her. So I really, I know for personal experience as a family member of a POTS patient that it's a very complex syndrome. Autonomic dysfunction affects everybody around, and I'll be here to give you an overview of what autonomic dysfunction is and how it happens and definition and so forth. Let's see. Yeah. Okay. So the current definition of autonomic dysfunction started in 1993, so we're looking at almost 20 years. The diagnosis originally was made in 1940 in the Mayo Clinic, where they start looking at people with recurrent episodes of syncope. There's a lot of different wording for autonomic dysfunction that came along over the last 20-30 years, but it's a very complex and heterogeneous disorder. There's over 500,000 diagnoses every year of autonomic dysfunction and POTS, and there's approximately 3 million Americans affected by this disorder. It is being in the Disability Act now, so it's important. And even for the military, they finally added to the list of disorders for which you can be medically discharged. And we see a lot of kids that unfortunately were undiagnosed before coming into active duty, and then they are severely affected by this diagnosis. There is multiple source of classification, if you want, but it's considered an acquired autonomic neuropathy. Some of these neuropathies are idiopathic. Some of them are associated with amyloidosis, and a lot of the ones we see are post-viral dysautonomia. Some of the ones we see have antibodies detectable against the ganglionic receptors. We don't often do this test, but we base our diagnosis on more simple tests. There's also a lot of secondary neuropathy that are associated with other conditions. Diabetes, we see Parkinson, we see chemotherapy, we see immunodisorder, Sjogren's syndrome, and then paraneoplastic disorders. So anything that will affect the response of the autonomic system will lead you possibly to some sort of autonomic dysfunction. There is also other group of disease that we see, trauma and TBI, which I unfortunately now see quite often, but I've seen cases when I was in St. Louis associated with motor vehicle accident, kids that are involved in car crash or whiplash or concussions in football players. Some women are triggered by pregnancy. Big surgery can do it, bariatric surgery can do it. The body doesn't ever come back to have a normal response to their adrenergic or the parasympathetic tone. So we see also more infrequently, but groups that are triggered by such events. We see also associations with other disorders, and I think EDS is the one that we see frequently in patients that have autonomic dysfunction. And also mast cell disorders, mast cell release syndrome. It's one of the things that we see in association with autonomic dysfunction. And it depends on, in the last particular group, it's more an issue of skin disorder, itching, vasodilatation, headaches. It can also affect the GI tract, and Dr. Weinstock will be here to discuss that in more details. A lot of the times, patients either go to the cardiologist or they go to the neurologist, or they're told that they have some sort of emotional anxiety. We see a lot of kids referred because they think they have anxiety disorder, but in reality, you stand them up and their heart rate goes to 130, 140, and that's obviously not a normal response, but just walking from the bed to the kitchen. The definition is an increase of heart rate greater than 30 beats per minute, or 120 for adults, 130, 140 for teenagers. And PADS per se does not have necessarily orthostatic hypotension. We can see hypoperfusion, and that's a cerebral issue, but you don't see patient becoming significantly hypotensive. We see other response to autonomic dysfunction, including malignant vasovagal, which is less common, and those are mostly young adults who, when they stand up, they go asystole. And those are considered more dangerous and more concerning. Some of these kids may need a pacemaker. It doesn't mean that you will have it for the rest of your life, but I actually recently received via Facebook a note from a patient that I saw at SLU when he was in the Billiken basketball team, and he had hypervagal tone, passed out all the time. But he wanted to continue to play, so I said, listen, if you want to play, you have to have a pacemaker, you don't have a choice. And now I think he's 40, and he hasn't had any more episodes. He had his pacing removed, but he was thankful that he was able to finish his college, his master, and his education. And now it's like, yeah, I'm free. But so some of these transient hypervagal episodes or periods of life may correct, especially in boys past the age of 25 or so. Another group that we see are elderly patients, and a lot of them are affected by autonomic dysfunction because of secondary neuropathy, diabetes, Parkinson, and they also are aggravated by the use of a lot of antihypertensive medication. So, and obviously syncope and autonomic dysfunction in the elderly is significantly compromising, and there's a lot of comorbidity, including fractures, hip fractures, and falls, and inability for these people to drive, and they become way more dependent on their family and their support system because they can't have a normal life. Alzheimer, dementia is another one that is recently, there's a lot of studies about autonomic dysfunction in Alzheimer's disorder, so whoever is caring for these patients, be aware that can't really leave them alone, beside the risk of ingesting inappropriate substance, but also because they fall, break their hip, or can be on the ground for a long time without being seen. The ratio is 4-to-1, 5-to-1 in some literature for men to women, to women to men, so guys are better when it comes to autonomic dysfunction and POTS. There is a lot of symptoms related to it, and I'm sure that all of you can fit in one of these category. Abnormality of capability of exercising, high rate during exertion. Some people were able to be super athlete and then they can't be super athlete anymore because the heart rate response is crazy. We see that in post-TBI a lot in the Army. If you have a trauma or an explosion, and then we do stress test, these people are reaching very, very high heart rate very early on exertion, which was not one of the characteristics that we saw, but even in the normal population, tendentially you have a much higher rate for exertion than you would have normally. Sweating and intolerance to heat, inability to stand up rapidly, going to the bathroom at night, for a lot of people, especially the elderly, become an issue. Digestive difficulty and poor appetite and bloating, constipation and so forth. The definition is variable. There's a lot of groups of POTS or autonomic dysfunction that you see at hypovolemia and venous pooling. Those are the people that really benefit from support socks and infusions. I know that this infusion has been a very controversial form of therapy. But finally, there is literature, and a study was published in the Journal of Interventional Electrophysiology in November of 17. I actually have a copy in the car where this group randomized POTS patient with hypovolemia to no fluids or fluids, and there was a significant benefit for these people to receive fluids, and I think I have a slide a little later about that. And then there's hyperrenergic POTS, patients that have persistent elevation of norepinephrine levels, and then small fiber neuropathy of the lower extremity, and then again the association with other syndrome that you can see. The hyperPOTS is less frequent, I would say, than the hypovolemia venous pooling form of POTS, but those are the patients that have transient episode of hypertension, that you really have to manage the hypertension and the hypotension at the same time. And these are the people that if you do norepinephrine and epinephrine levels, they tend to run higher level. Once you have high norepinephrine or epinephrine level, you also have a lot of the quote-unquote brain fog that a lot of the patients with POTS have. So I think that it is very common to see this abnormal, cerebral perfusion responses in patients with POTS. The vasoconstriction in the neuropathic POTS it's an issue, so people tend to visit dilate all the time. Have venous pooling, so that's why we recommend the abdominal binders, which will help you with shunting the flow from the abdominal wall, the abdominal intracavity, the liver, the spleen. They contain a lot of fluids back into the circulation. And we recommend it, especially in women that don't want to wear the support socks quite often, or the support socks are the other alternative. There has been studies that have also used the eye infusion rates frequently. We tend not to do that, and I think you don't want to have patients become completely fluid dependent, but most of the patients that have infusions during their life that have hypovolemic POTS or with adaptation, they could do okay with a couple of liters a week or maybe twice a week, and then eventually some people really are able to wean themselves off by learning how to drink water, take salt, take supplements. So, as far as the hypertensive response in the patient that have hyperPOTS, it's very variable and fluctuating. So we do see elevated norepinephrine level. People have pale and cold hands, and some people have hot bodies and freezing hands and feet. That's something that we see quite often in patients with POTS. So we try to tell them to use cooling vests, cooling pads for their core to try to bring the temperature back to normal. A lot of times, everybody says I need super thick socks, and in the winter, it's almost like having a Renault phenomenon, but it really is not. It's just a reflex vasoconstriction of the lower extremity. The GI symptoms are frequently associated by hypovolemia, and I think Dr. Weinstock will talk about that. I think he also has uses infusions in these patients that have low volume and volume dysregulation, and that's probably about a 30% of the POTS patients. And this is the study that I was talking about. It was published in 17. They had about 72 patients that were tried or on an average of 3.6 medication to control their POTS symptoms, and they received about average of 1.6 liter of fluids on an average of 7 to 10.2 days. And when they did orthostatic hypotension questionnaire, the patients that were randomized to infusion that did much better than the patient that were not getting infusion. So there is some data that supports this now. It's not just a bogus form of therapy. So it's available for people. There are people that have issue with access. The biggest question that I always get in patients that are getting infusions is the port cap placement versus peripheral IV. So I try not to recommend ports for young people, or especially children, because once you start using subclavian and so forth, if you add an occlusion, then it becomes a problem in the long run. But people, adults, men that have large vein, you can do that. In cases in which we have seen autonomic dysfunction post-ICU care and patients have been sick with sepsis and so forth, we sometimes use PICC lines. They're a little less invasive, and they can be kept on for a couple of weeks at least until the acute phase resolves and the patient resumes oral hydration. The cognitive and psychological issue of POTS comes up a lot, and I did a little research, and actually it was very interesting to see that the research that's been done on POTS and foggy brain and whatnot, it's actually consistent with a lot of symptoms similar to ADHD, except that the patient don't have the hyperactive characteristic. They only have the decreased concentration with the cognitive dysfunction. There is some theory that supports the fact that there is a dysregulation of the norepinephrine system in patients. That's why you have this response. So there is 2009 NIH literature that you guys can look up on the psychiatric profile and attention deficit in POTS patients. So there is multiple questionnaires that have been done, multiple data that supports the presence of concentration deficit, but not the hyperactivity part in patients with POTS. So the big issue is how you treat it, and there is, even in the NIH literature, there is not the data on Adderall is yes and no. It is not really any randomized study has been done. If you look at the current literature on cognitive and psychological disorder impacts, Vanderbilt is doing now, and I think they're still enrolling a study with Provigil in patients that have fog, brain fog, and concentration issue, which I thought was interesting. At least there is some efforts to treat it, and also there is acknowledgement of the fact that, you know, it is one of the symptoms that is present in POTS. There is also what we call behavioral amplification. So once you get caught into this cycle, you go on and on and on, and it's a vicious circle. So people become hyper aware of their symptoms. And so really a lot of, for instance, KU Med is very involved in doing yoga and meditation and other form of, you know, mindful thinking, so you remove yourself from this behavioral amplification, hypervigilance, and so forth. The sleep disorders is very frequently associated with POTS too. So I tend not to use sleeping pills. I usually tell people to have sleep hygiene, don't watch TV, don't be under, you know, bright lights, and have a normal cycle. But there are some patients that really can't sleep at all, and that you might have to break down and use some form of sleep aid without going to benzo, obviously. Considering the benzo epidemics of these days. Bariatric surgery, we see a fair number of patients with bariatric surgery that develop POTS. And mostly it's because there is a rapid weight loss, the body is not adapted rapidly to the change. The hypocaloric diet and protein diet that is given before creates autonomic dysregulation. And a lot of times this might go away, but I've seen several patients that end up having to take medication for mostly orthostatic intolerance, so Northera or, you know, midodrine, alpha agents, and support stocking, and again, try to exercise, try to build muscle tone, try to do all the things you need to do when you have rapid weight loss. I think that it's more of a, I've seen it, at least a personal experience, way more in female patients that I've seen in male patients that underwent bariatric surgery, but is to keep in mind that that's one of the things that can certainly happen. Rapid weight loss, change in protein diet, and so forth can lead you to autonomic dysfunction and orthostatic intolerance. Important things to do, obviously, interview the patient. It takes quite some time to get to the bottom of a diagnosis. A lot of the patients we see have been around and seen a lot of specialists. I think that now there's way more awareness in the field of autonomic dysfunction, especially in this community. There's some people that have taken interest on caring for patients with POTS, and so there's support groups, there is a community that helps. Although I still see that internists don't want to hear about it. I mean, we've had actually people that said, oh, why you guys doing all these pills? You shouldn't do them, or you make all this fake diagnosis. Well, really, nobody makes fake diagnosis. If you see somebody has an autonomic dysfunction response on a tilt, people don't make it up. It just happens. But it's amazing. I see it even on post. The internists don't want to acknowledge it. So patients are not very happy with the way they're living for the most part. But tilt table remains pretty much the key test to do. And then some of the more advanced labs do a lot of blood work. I think that one of the things to do is the norepinephrine level. If you're dealing with an hyperpulse, at least you can confirm the diagnosis. You can do the quantitative pseudomotor axon reflex testing, which is a series of testing that tests both autonomic, parasympathetic and adrenergic tone, and then you can come to, your conclusion of which POTS group you will fit the patient into. This is one of the scoring, the CAS scoring most of the time. The positive tilt gives you at least a 4 point. So less than 4, you have mild autonomic dysfunction. More than 4 to 6 is moderate, and then severe are patients that have all sort of other concomitant autonomic abnormalities, sweat disorders, tachycardia, dysmotility, and so forth. So this is kind of a more, if you want, newer way of classifying autonomic dysfunction. Vanderbilt uses this much as well as the Mayo Clinic does too. And they have big autonomic dysfunction centers, so people that are unsure about their diagnosis or want more details about the diagnosis certainly can go to either Vanderbilt, Cleveland Clinic, or Mayo Clinic, where they have actually autonomic dysfunction disorder centers where they do every possible test you can ever think of. Often, the ones that I've seen go on, most of the time the diagnosis is confirmed, and there is some extra, testing that gets done, especially in reference to the peripheral neuropathy, the blunt autoimmune disorders, and so forth. Your friend is water. Everybody knows that. So POTS patient, they need to carry around a little bottle all the time. We recommend 3 to 4 liters. People that are outside all the time, even more. We recommend support garment, exercise training, isometric exercises. It's really important, and really change your lifestyle. Really be aware of the good days, bad days. I think it was last year when Dr. Kinsella showed a slide of consider your life from 1 to 10 and just see where you can fit. Most of POTS patient will live at a 5 or a 6. If you have a 10-day, be happy, enjoy, and try to stay away from the 1 and 2 days as much as you can. I think that, again, the hypervigilance and the behavioral awareness, it's a big component of where you place yourself in a 1 to 10 scale. So avoid hyperstimulation, avoid situation that will create triggers. I think yoga and meditation, it's very, I recommend it a lot. I saw the benefit that, my personal experience with my kid, she had a really big turnaround by doing yoga and changing her diet, staying away from carbs, doing a lot of isometric exercise. I mean, she did a triathlon this summer, so she went from spending 5 hours a day in bed to being very, very physically active. So you can transform your life by putting, your mind to it. The drugs we use, it's a potpourri. I don't think that anybody really can say, oh, I take this and it's excellent, and I take that and it's terrible. I think beta blockers and Florinef, most of the young teenagers are hypovolemic. They don't drink enough, they forget to drink. I think the Florinef is one of the drugs that we give them quite often. It's easy, it's a small pill, once a day. We usually give potassium with it because one of the side effects of the fluorocortisone is hypokalemia. So you don't want them to become, have low potassium and have muscle cramps and whatnot. But, and the beta blockers, especially in patients that have POTS with extreme high rates. Erythropoietin, I mentioned it a little earlier. It may be effective in patients that are anemic, they have diabetes, and other sorts of renal insufficiency and whatnot with orthostatic intolerance. I have never used in the POTS population, and I see most of the people I see are pretty healthy. And then Northera, that has been actually a pretty good drug. It's a dopaminergic medication, and it's very useful in patients that have persistent orthostatic hypotension. And then Corlanor, iradodine, which in Europe it's released for the use in POTS. In the United States is not, and a lot of insurance now are getting really strict, this prescript in particular. If you are unsuccessful with the beta blocker to control your heart